what if, trying to physically enhance your own sexual pleasure, actually, and I mean, practically guaranteed you severe stabbing pain?
Right. It sounds completely counterintuitive.
Yeah, exactly. Imagine you are, looking to improve your experience. You undergo this highly localized procedure that's designed specifically to magnify physical sensation.
Mm-hmm.
But instead of heightened pleasure, your body reacts with this just intense, agonizing biological crash.
Which is, frankly, a very real mental paradox. I mean, when we try to force a localized upgrade onto a biological system without really evaluating the surrounding environment first, the results can be completely counterproductive.
Yeah.
The intervention just overwhelms a system that is, already quietly failing in the background.
And today, we are looking at exactly how that happens. We are diving into the incredibly complex and honestly, highly misunderstood intersection of aesthetic sexual enhancement and pelvic floor function.
Oh, absolutely. It's such a crucial intersection.
Right. So our mission for this deep dive is to figure out how a hypertonic, meaning a spasming pelvic floor, actually interferes with and can completely ruin the intended effects of a G-spot amplification procedure.
Yeah. The interference is massive.
It really is. And we have a fascinating stack of sources for you today. We're pulling from clinical literature on vulvovaginal disorders, some really dense excerpts on pelvic floor biomechanics, and, physical therapy diagnostic criteria.
Which is so important because, well, looking at any of those fields in total isolation just doesn't give you the full picture.
No, not at all.
You really have to layer the structural anatomy with the localized neurology to see why this specific intervention fails so spectacularly under the wrong conditions.
Absolutely. So whether you are a medical professional trying to bridge these specialties or someone curious about sexual wellness or just, fascinated by how interconnected human anatomy truly is, we're going to show you how tweaking one small gear can bring the entire machine to a grinding halt if the foundation isn't sound. Okay, let's unpack this.
Let's do it.
Before we look at the structural collapse, we really need to understand the biological target. So let's talk about the G-spot and this specific enhancement procedure. What is the actual anatomy we are looking at here?
Right. So to start, we are looking at what's medically known as the Grafenberg spot.
Okay.
And historically, I mean, there was a lot of debate about whether this was a distinct standalone organ or, just a total myth.
Right, like the elusive magic button.
Exactly. But current clinical literature has actually mapped this out very clearly. It is a highly sensitive zone located on the anterior or the front vaginal wall.
Okay, the front wall.
Yeah, and geographically speaking, it sits about 1 to 3 inches inside and roughly 2 centimeters below the urethra.
I remember reading in our sources that it's part of something called the CUV complex, right? The clitorithrovaginal complex.
Yes, the CUV complex.
So it isn't just like a floating dot in the middle of nowhere. It's an intersection of things.
That is actually the perfect way to visualize it. It's a dynamic, incredibly vascularized intersection where 3 distinct structures physically overlap.
Which 3?
You've got the vaginal wall, the urethral sponge, and the internal deep tissues of the clitoris all meeting right there.
Oh, wow. So it's very crowded.
Very. And because you have all these distinct networks converging in one single location, it creates this localized region with just an incredibly dense concentration of sensory nerve endings.
And so when a person becomes aroused, this area naturally swells, right? It engorges with blood, which triggers those pleasurable sensory responses.
Exactly. That's the baseline healthy function.
Which leads us to the clinical enhancement, which is often called the G-shot.
Yeah.
But if this area is already so packed with nerves, what is the medical procedure actually trying to accomplish? What are they doing?
The clinical approach is actually remarkably straightforward. A physician will apply a local anesthetic, and then they inject a bolus or a volume of medical-grade filler directly into this CUV complex.
Wait, like face filler?
Yeah, exactly. The materials used are usually hyaluronic acid or collagen. I mean, these are literally the exact same FDA-approved fillers that dermatologists use for facial aesthetics.
Like Juvederm or Restylane.
Right, to plump up lips or smooth out wrinkles.
That's wild. And based on the clinical literature, they aren't just putting, a microscopic drop in there.
No, not at all.
The goal is to inject enough filler to physically enlarge the target area to about the size of a quarter and to thicken it so it actually protrudes by about the width of a pencil eraser.
Which is a significant amount of localized volume.
Right, and that effect lasts for, what, about 4 to 6 months before the body absorbs it?
Usually 4 to 6 months, yeah. And what's fascinating here is the underlying biomechanical logic of why this procedure is even performed.
Okay.
See, the filler isn't altering the cellular chemistry of the tissue.
Right.
And it is definitely not magically growing new nerve endings. It relies entirely on basic, simple physical volume.
Just taking up space.
Exactly. By increasing the physical profile of this specific nerve-dense tissue, you are essentially forcing it to project lower and much more prominently into the vaginal canal.
Oh, I see.
You are purposefully decreasing the available physical space in that one specific spot.
To guarantee more friction. I mean, it sounds like taking a sensory highway and building a targeted speed bump right in the middle of it just to ensure that the tires hit it and register the contact during intimacy.
I love that. That analogy captures the mechanics perfectly. You are modifying the local geography to force stimulation.
Right.
And the literature shows that for a woman with, normal, healthy sexual function and a highly relaxed pelvic environment, that added physical volume can significantly heighten arousal. In a healthy system, the filler does exactly what it is engineered to do.
But, if we are building a speed bump, what happens if the road beneath it is structurally compromised?
That's the big question.
Right, because for that extra friction to actually register as pleasure, the surrounding environment, meaning the vaginal canal, has to be receptive. It has to have the flexibility to actually accommodate that new volume.
Right, and that brings us to the literal floor beneath this entire structure, the pelvic floor.
I want to pause here really quickly because I think, for a lot of people, the term pelvic floor just brings to mind like a flat trampoline sitting at the very bottom of the
A
torso.
lot of people picture it that way, yeah.
But the biomechanics in our sources describe something much more intricate than that.
Oh, it is far more intricate than a flat trampoline. The pelvic floor is actually this complex, funnel-shaped structure.
A funnel.
Yes. And it's composed primarily of a muscle group known as the levator ani. Together with various layers of connective tissue, they form this multi-directional sling.
And what does that sling actually do?
Well, it supports the bladder, the uterus, the rectum, and the vaginal canal. I mean, these muscles maintain our continence, they provide essential core stability, and they're intimately involved in sexual function.
Right, and for sexual function to work correctly, this sling needs to be dynamic.
Yeah.
It needs to be able to relax.
Absolutely.
So what happens when that system breaks down? Because our sources focus heavily on this one condition called high-tone pelvic floor, or HTPF.
Also referred to clinically as levator ani syndrome.
Right, levator syndrome.
So HTPF is a state of chronic involuntary muscle spasm. The levator ani muscles become completely locked in a contracted state.
Wow.
They are shortened, they're tight, and they remain completely rigid even when the person is perfectly at rest. Imagine like a severe ongoing cramp deep inside your pelvis that you just cannot consciously release.
And when I was reading through the physiological data on this, what honestly shocked me was that this isn't just about feeling a little stiff or tight.
No.
The biochemical chain reaction that happens when these muscles lock up is terrifying. I mean, the literature notes that just a 10% increase in pelvic floor muscle tone causes a staggering 50% decrease in blood flow and oxygen to those specific muscles.
That singular statistic right there is the linchpin of this entire biological cascade.
A 10% increase cuts blood flow by half.
Yes. Think about that ratio. A barely perceptible increase in baseline muscle tension manages to essentially choke off half of the vascular supply.
That's insane.
It is. And when muscle tissue is starved of oxygen, a state we call ischemia, it can no longer perform normal cellular respiration.
So what does it do?
The tissue is basically forced to switch to anaerobic metabolism just to survive.
And the byproduct of anaerobic metabolism is lactic acid. Like, when you do way too many squats and your legs burn.
Right.
But here, this is happening constantly while you are just sitting completely still.
Exactly that burning sensation, but localized deep within the pelvis. The oxygen starvation leads to this massive buildup of lactic acid alongside powerful inflammatory markers.
Like what kind of markers?
Things like bradykinin and various cytokines. You essentially end up with a toxic chemical soup just pooling in the muscle fibers.
So it's an active chemical pain loop.
Yes.
The tissue is essentially suffocating itself. But how does that affect the nerves in the area?
Well, the lactic acid and all those inflammatory cytokines severely irritate the sensory nerves that pass right through the pelvic floor.
Oh, because they're bathed in it.
Exactly. The nervous system registers this chemical irritation as localized pain. And here is where the loop really closes in response to pain. The body's natural protective reflex is to guard.
Meaning the muscles instinctively clench even tighter,
You got it.
which would then cut off the oxygen even more, creating even more lactic acid. I mean, this sounds like a nightmare. It's just marinating in its own warning signals.
It truly is a nightmare for the patient. And over time, this constant bath of chemical irritation actually alters the behavior of the nerves themselves.
Really? How?
It creates a state called hyperalgesia, which is an extreme, massively amplified sensitivity to pain.
So the nerves get reprogrammed.
Essentially, yes. When a patient has hyperalgesia, non-painful stimuli, things like light pressure, normal touch, or even standard friction are suddenly interpreted by the brain as burning, stabbing, or severe aching. The nervous system's baseline threshold for pain drops to almost zero.
Here's where it gets really interesting and where we hit the core of our mission for you today. We have to look at the collision of these two realities.
The collision is where it all falls apart.
Right. So imagine a patient who is experiencing sexual dysfunction. Maybe sex feels uncomfortable, or they're having trouble reaching
A
orgasm.
very common scenario.
They might think, I just need more physical stimulation. I should get a G-shot. But they have no idea that their lack of pleasure is actually stemming from this undiagnosed suffocating muscle spasm.
Exactly. And this is the exact moment the localized upgrade collides with the failing foundation.
Let's break that down.
Sure. So the G-spot bolus is, by definition, a space-occupying intervention.
Right, the speed bump.
Right. It relies entirely on creating a prominent bulge to increase physical friction against the vaginal wall. But if a woman has levator syndrome, the physical space of the vaginal vault is already severely restricted.
Because the muscles are clamped down.
Yes, those hypertonic muscles resist any passive stretch. They are actively clamping down on the canal.
Right, because if a patient has HTPF, our sources show they already have symptoms like dyspareunia, which is the clinical term for painful sex.
Very painful.
They're already experiencing burning, rawness, throbbing, and a constant feeling of pressure in the vagina. So they seek out this injection thinking it will fix their sensory issues. But the physical volume of the filler is just taking up space in a canal that physically refuses to expand.
It creates severe mechanical crowding.
Mechanical crowding.
Yes. The intended subjective sensations of the filler, that highly pleasurable stimulation of the CUV complex we talked about, are completely overridden by the nervous system.
Because of the hyperalgesia?
Exactly. You have to factor in the hyperalgesia. The sensory nerves in that area are already bathed in lactic acid and bradykinin. Their danger signals are firing at maximum volume before the procedure even begins.
So that sensory speed bump we built
Is now grinding aggressively against a muscle bed that is chemically and physically screaming in pain.
Wow.
The human nervous system simply cannot process pleasure when it is overloaded with acute danger signals. Any friction on that newly enlarged G-spot is viewed through a biological lens of severe inflammation.
It's all danger.
All danger. And to make matters worse, you've just added volume to the filler itself, which creates even more localized physical pressure in an environment that is already suffering from involuntary constricting spasms.
It sounds like inflating a balloon inside a rigid metal pipe. I mean, the pressure has nowhere to expand, so it just creates intense, localized pain. You are literally guaranteeing that the friction targets the exact tissue that is hypersensitized to register friction as a stabbing sensation.
Which highlights exactly why understanding the foundational mechanics is non-negotiable here. If the levator is in spasm, the G-shot doesn't just quietly fail to provide pleasure.
It actively makes it worse.
It actively worsens the mechanical crowding and amplifies the sensory overload in the vaginal vault.
So how on earth do doctors figure out if the problem is the speed bump or the road itself? I mean, if injecting filler into a hypertonic pelvic floor is essentially pouring gasoline on a chemical fire, what are the diagnostic tools? How do they identify this spasm before making a catastrophic mistake?
Well, this requires a highly specific evaluation that goes far beyond just a standard routine gynecological exam.
What do they do?
According to the physical therapy and urogynecology sources we're looking at, specialists rely on several specific tools, and one of the primary ones is surface electromyography, or SEMG.
Okay, I'm vaguely familiar with EMG for, nerve testing in arms and legs, but how are they using it here? What are they actually looking for?
They are measuring the electrical activity of the muscle fibers. So, in a healthy pelvic floor at rest, the SEMG should show a relatively quiet, flat baseline.
Like the muscles are fully off.
Right, they're off. But in a hypertonic patient, the SEMG shows an elevated resting tone. You see constant erratic electrical activity.
Oh, wow.
Yeah, it literally proves that the muscles are constantly firing and exhausting themselves when they should be perfectly still.
The sources also mentioned imaging. I think it was 3D and 4D ultrasounds.
Yes, and the ultrasound is critical because it visualizes the actual architecture of the pelvic floor in real time.
What does that look like?
In women with conditions like provoked vestibulodynia, which often accompanies HTPF, the ultrasound physically reveals a much smaller levator hiatal area.
Meaning the physical opening of the muscular sling is visibly constricted on the monitor. Like they can literally see the narrowing.
They can see it and they can precisely measure it, and that imaging is usually paired with manual palpation.
Manual palpation.
Yes. Specialists use a diagnostic framework called the Oxford Grading System to evaluate muscle contraction and relaxation manually.
Oh, man. That sounds incredibly painful for a patient who is already dealing with hyperalgesia.
It is deeply uncomfortable, unfortunately, but it's diagnostically necessary. The practitioner is physically feeling for myofascial trigger points.
Like knots.
Exactly, literal tight bands or rigid knots deep within the pelvic muscles. They're assessing if the muscle tissue feels thick and taut, and most importantly, if it actively resists passive stretching.
Okay, while we're on the topic of testing the muscles, I saw something in the notes about dynamometry that, honestly, it just broke my brain for a minute.
Oh, I know what you're going to bring up.
Right. The sources noted that women with this condition obviously have a higher vaginal resting pressure because of the spasm. But then it said that having the patient contract their pelvic floor maximally can actually reduce that resting pressure afterward.
Yes.
Hang on. You're saying making a clenching muscle clench harder makes it relax. I mean, that makes zero sense.
Yes. It does seem completely counterintuitive, but it relies on a fascinating physiological loophole called paradoxical relaxation, or sometimes it's called post-isometric relaxation.
How does that even work?
Think about the chronic spasm. When a muscle is locked in a low-grade involuntary spasm for months or even years, the brain has essentially lost conscious communication with it,
It's just stuck on autopilot.
stuck on autopilot in a rigid state. By instructing the patient to execute a maximal voluntary contraction like clamping down as hard as they possibly can, you are forcing the central nervous system and the muscle to talk to each other again.
Oh, I see. You were overriding the autopilot.
Precisely that. Once that maximum voluntary contraction ends, the neurological system forcefully resets the muscle to a lower baseline resting state. It effectively breaks that static involuntary feedback loop.
That is incredible. It's essentially like turning your frozen computer completely off and back on again just to clear the RAM. You have to
Yeah.
reboot the muscle.
It perfectly reestablishes neuromuscular control. And that concept of retraining the brain-muscle connection is a massive part of the treatment protocol.
What does that entail?
Pelvic floor physical therapy and biofeedback are usually the first line of defense. Biofeedback allows the patient to actually see their muscles' electrical activity on a screen in real time.
Oh, so they can visualize it.
Yeah, which really helps them learn how to consciously downregulate those electrical spasms.
But our sources also highlight treatments for the severe cases, right? The ones where the chemical pain loop is just too entrenched for physical therapy to break through on its own.
Yes, there are medical interventions.
And one of the medical interventions mentioned really threw me off, which was Botox. Wait, Botox. In the pelvic floor. I mean, I thought that was strictly for freezing forehead wrinkles or cosmetic stuff. Isn't it dangerous to put a paralytic down there?
If we connect this to the bigger picture, Botox is widely misunderstood by the general public.
I mean, clearly I misunderstood it.
It's known as a cosmetic wrinkle smoother, sure, but its application in pelvic floor dysfunction is highly sophisticated neurochemistry. It is remarkably effective for levator syndrome because it utilizes a dual action mechanism.
Dual action. So it's not just paralyzing the muscle. What is it actually doing on a chemical level?
Well, the first action is the motor block. It works at the neuromuscular junction by blocking the release of acetylcholine.
Acetylcholine being the neurotransmitter.
Exactly, the specific neurotransmitter that tells a muscle fiber to contract. By blocking it, you cut off the command. You physically force the levator any to finally stop spasming. The muscle is forced to lengthen and relax.
Which, going back to our chemical loop, that instantly stops the oxygen starvation. It halts the production of new lactic acid.
That is the first victory, yes. But the second action is arguably just as important for these patients.
What's the second action?
Clinical studies show that Botox also reduces the release of specific pain-signaling neuropeptides from the peripheral nociceptors. Those are the sensory nerves.
Wait, so it isn't just stopping the physical cramp, it's actually silencing the pain alarm itself.
Yes. It actively mutes the sensory pain signals traveling back to the brain. It shuts down both halves of the hyperalgesia loop simultaneously.
That's amazing.
It really is.
Yeah.
It stops the mechanical crowding and turns off the chemical fire all at once.
So what does this all mean? It means that if a patient wants any kind of aesthetic or sensory augmentation, like a G-Shot, they absolutely have to address the underlying biomechanics first. You have to clear out the lactic acid, you have to stop the hypoxia, and you have to release the levator and attention before that targeted speed bump can actually do its job.
Without a doubt, you cannot view sexual wellness strictly through the lens of surface-level mucosal enhancement.
Right.
The vagina is not just a static tube. It is a dynamic, highly integrated fibromuscular ecosystem. The mucosal layer where the filler goes, the vascular supply, and the deep myofascial layers beneath it are all entirely interdependent.
They rely on each other.
Completely. You simply cannot successfully treat or enhance one layer without ensuring structural homeostasis in the others.
Which brings us right back to where we started. Human anatomy is a highly interconnected web. You can't put a high-performance upgrade on a machine that is actively collapsing under its own tension.
Exact.
For you listening, whether you're, navigating your own health journey or just geeking out on the biomechanics with us, this underscores why comprehensive medical evaluations are so vital. We have to look at root causes like muscle tone, oxygen starvation, and chemical pain loops, rather than just throwing a localized aesthetic treatment at a symptom and hoping for the best.
It's really about respecting the body's structural reality. When we ignore the foundation, the body has a very loud, very painful way of forcing us to pay attention.
It really does. And I want to leave you with a final thought to ponder, based on the incredible data in these sources. We learned today that just a tiny 10% increase in pelvic muscle tension can slash local blood flow in half, kickstarting a self-perpetuating, agonizing chemical pain loop. We also know from broader medical literature that the pelvic floor is highly reactive to emotional stimuli. It is a core biological center where the human body instinctively holds stress, trauma, and anxiety.
Oh, absolutely.
So, given how much unconscious everyday emotional stress we naturally carry around with us while sitting at our desks or while driving in traffic, how much of our daily physical discomfort or even our baseline sexual experience is secretly being dictated by a subtle, unacknowledged muscle spasm we don't even realize we're holding? If tweaking the machine without checking the foundation causes a crash, we might want to start checking our own foundations a little more often.